presentations. First, we'll start with Dr. Öztürk. She will present a case about glaucoma and myopia revisited.
Thank you. Good afternoon. Myopia is growing in an exponential rate, and in our glaucoma practice, myopic cases often create a dilemma and is difficult to evaluate in the light of our classical knowledge of glaucoma. So my talk will be about shifting our focus and changing our perspective in this group of patients. High myopia is defined as having an axial length of more than 26.5 millimeter and a refraction less than -6 diopters. And primary open-angle glaucoma is extremely common in these cases. In particular, in eyes having more than 28 millimeter of axial length, glaucoma occurs about in 1/3 of these cases. And detection of glaucomatous optic neuropathy is difficult clinically and technically, and there is no information about the natural course, under intraocular pressure lowering treatment, and visual field and OCT findings, as well as clinical examinations, may very well mimic or mask glaucoma in these cases. Sorry. So why is it more challenging to diagnose glaucoma in myopia? Because these typical glaucomatous findings in the optic disc are not simply to distinguish in myopic eyes due to disc shape, shallow cupping, large peripapillary atrophy, rotation or torsion of the optic nerve, and lamina cribrosa defects and temporal shifting of the RNFL. The neural tissue and its supporting connective tissue are different in myopic eyes as well. So far, apart from RNFL, research has focused on the ganglion cell layer, neural rim, lamina cribrosa, choroidal thickness, peripapillary sclera, and Bruch membrane opening. And apparently, there is a remodeling of the sclera and lamina cribrosa in myopic eyes. The mechanical stress at the lamina cribrosa and accompanying scleral expansion cause axonal damage with the contribution of iomia and ischemic factors. And in these cases, lowering IOP alone may not prevent the disease from progression. And at a pathological level, we need more clinical studies and classification in order to diagnose glaucoma with conventional diagnostic devices. And what challenges do we have recently in the diagnostics? In the visual field testing, we may encounter variable losses during the follow-up. Defects may be indistinguishable from myopic changes or may follow a different glaucomatous pattern if there is glaucoma. And very recently, an international research consortia classified visual field defects in non-pathological myopic eyes. And the most common visual field defects were nasal step, partial arcuate defect, enlarged blind spot, and non-specific defects which were associated with longer axial length and older age. And we have to watch out visual fields very carefully because large percentage of myopic discs are tilted with peripapillary atrophy, which can lead to mimic glaucomatous visual field defects. And myopic visual field defects may progress differently. We have to focus on extension of the defects or the new defects, and frequent tests for sure will help to confirm true changes over time. And what do we see in OCT? We may identify pseudo-RNFL thinning, which we know as red disease, and reference database can be misleading unless there is a myopic database, and Bruch membrane opening may be difficult to analyze for the evaluation of the rim area. And macular ganglion layer has been shown to have a better diagnostic value than RNFL thinning, unless there is a myopic maculopathy for sure. And in clinical examination, when optic nerve head is a challenge to interpret, macula may be more informative in myopic eyes as well. I would like to present two cases showing the challenging patterns of myopic glaucoma. My first case is a 74-year-old gentleman with high myopia and advanced glaucoma in both eyes. And this is the fundus picture. It shows you a very typical fundus with large discs, with large cup that is sloped, and with very significant parapapillary atrophy. Macula showed a myopic atrophy with an extreme ganglion loss, and although he had bilateral traps and was on maximum medical treatment, he had above the target IOP, and there was a progressive central threat in the visual field of the left eye. A red trap was planned on the left eye, and in the 3-year follow-up, although the IOP was low in the low teens and vision was stable, there was an ongoing functional progression. And as I mentioned in my prior slides, lowering IOP may not prevent disease progression if it is glaucoma. My second case is a younger patient presenting with high myopia, larger discs with shallow white cupping, intraocular pressure is in the low 20s, there is no family history of glaucoma or steroid use, there is a partial peripheral rim in the right visual field and no obvious defect in the left. In OCT, here is nerve fiber layer thinning, which may suggest red disease. And macular analysis was non-applicable due to low cooperation and sinal strength. We're not so sure if it's glaucoma or not, but such eyes may not be very suitable candidates for the wait and see strategy, and they are much more sensitive to IOP fluctuations unless the IOP is very low. For this reason, we consider to start medication in this patient. During the follow-up, visual field progressed despite stable IOP and vision. The RNFL thicknesses were very much variable during the follow-up. That did not give us a reliable information about the progression. I'm sure you have encountered similar situations in your clinic, and traditional IOP measurement and structural and functional evaluations may not apply in this special subgroup of patients. IOP measurement is also a challenge. If the IOP is normal, it makes the diagnosis and follow-up more challenging. We may need to check the diurnal variations, and there is greater IOP fluctuation in high myopes than in non-myopes with primary open-angle glaucoma. So we can say that there's a certain clinical entity which looks like glaucoma but has different behavior. These patients may have glaucomatous optic neuropathy, myopic optic neuropathy, or both. To our current knowledge, the only key to figure out glaucomatous progression is the longitudinal topographical agreement between structural and functional damage. So very reliable baseline measurements are essential in these patients. Future research on optic nerve head morphology to identify specific biomarkers with the contribution of deep learning algorithm may enhance our ability to manage these patients in glaucoma. Thank you.
Thank you very much for addressing this very confusing coexistence between myopia and glaucoma. Can we invite Dr. Gupta for present his case on the Ahmed glaucoma valve in a patient with an iridia repositioning? I think he's not around. So can we invite Dr. Ali, please? He will discuss about congenital glaucoma and his surgical priorities.
Yeah. Good afternoon. Yeah, it's okay. I will speak about congenital glaucoma and Sturge-Weber syndrome. Should change my surgical priority? No financial interest, sure. This is as introduction for Sturge-Weber syndrome. We know this syndrome characterized by intracranial and facial angioma, hemangioma of the lid, episclera, conjunctiva, iris, cilia body, or choroid. On all this picture from the second case that I will present now. A glaucoma occur in 30 to 70% of individuals with Sturge-Weber syndrome. If the upper lid involved, they are more likely to develop glaucoma. Glaucoma and Sturge-Weber syndrome, 60% develop before the second year of age, and only 40% later in childhood or adulthood. That's the problem in glaucoma. This is here, there may be anterior chamber angle anomaly or elevated episcleral venous pressure, and very rarely if there is retinal detachment and forward displacement of the iris and secondary angle closure glaucoma. Our problem with Sturge-Weber syndrome, still until now, no large, also this is very rare cases, but this is for that, no large long-term study that dictate the optimal management of a glaucoma patient in Sturge-Weber syndrome. The problem with the glaucoma in Sturge-Weber syndrome is more difficult to control than other forms of glaucoma. Also, high risk of surgical complication, less response to medical therapy, maybe response to aqueous suppression on meiotic medication. The two types, the early onset of Sturge-Weber syndrome caused by the angle anomaly, first line of therapy usually goniotomy or trabeculotomy or combined trabeculotomy with trabeculectomy, but still less successful than primary congenital glaucoma. The second type, the juvenile or late onset glaucoma, the first therapy as adult therapy can maybe with topical, but also frequently failed this medication. The second treatment is trabeculectomy. This is discussed with trabeculectomy. Glaucoma drainage device result comparable to the other study. There is many study also as primary implantation in this disease. For me, I keep always any implantation to the as the last we discussed now. A primary combined trabeculectomy also has been successful rate. Cycloablation usually reserved for failed Sturge-Weber syndrome patient. Also discussed there is good successful rate for non-penetrating surgery because less risk of choroidal effusion. We know that this intra and post-operative complications are more common. Explosive choroidal hemorrhage and sudden intraoperative choroidal effusion also has been reported. A prophylactic posterior sclerotomy also is debated. To reduce the risk of a glaucoma, can we lower the pre-op IOP as we can by hyperosmotic medication, any medication to reduce the IOP as we can? There is also discussed about treating the choroidal hemangioma with radiotherapy prior to intraocular surgery, and we can reducing the time of the surgery that the time is open, especially in trabeculectomy, by closing the eye as soon as possible. Sturge-Weber syndrome has severe glaucoma more than primary open glaucoma, that is an adult. Several small studies with relatively short follow-up have reported eye to have good outcome with vision better than 20/40. For me, this is my priority to go directly to trabeculectomy or combined trabeculectomy to overcome the both mechanism this is for the glaucoma. I keep trabeculectomy alone. I don't prefer alone. A glaucoma drainage device, I keep the second line. I don't go in any child, at least in any child, to implant glaucoma drainage device. This is also discussed because as many study, even implantation, Bervelt implant in this type, but also discussed this is the study about two stages. Implant at first the blade, and after that, second step, implant the tube after the encapsulation around the blade to reduce the hypotony, and they documented with good with good successful rate, but also here we go to the child two times for the operation. This is the first case I will present. This child presented to me in 2016 with cloudy megalocornea for management of glaucoma. This child had also facial hemangioma and brain hemangioma. This is later on 2080, this operated brain operation. This is the finding. You see this is here typical. This is also the color of the fundus. This is here with choroidal hemangioma, IOP 25, all parameter with secondary congenital or congenital glaucoma at the left side with the Sturge-Weber syndrome. According to my priority, I go directly to make trabeculectomy with a small trabeculectomy. As normal, we go, this is here, apply metomycin, cautery, and after that, we open the flap. Here, we open of the Schlemm canal. Always when I open, I make two opening at the side to see the Schlemm canal wall, and after that, I make trabeculectomy with a small iridotomy also, and close. See the bleeding from the angle. Don't be worried from that. This is resolved in 3-5 days to 1 week. This is the result of our 5 years from the follow-up. Everything go very well. This is after trabeculectomy here. That's the pressure on both eyes. Go very well. After that, now the last year started the IOP slightly go up in the left eye, and instead of this compared to the left eye, but still the axial length growth of both eyes parallel. The corneal thickness is not decreased at all. Also, the corneal diameter grow parallel is not increased more and more at the left side with control. Now we come to the second case. This is present recently for me. This is 5 weeks baby with also the same scenario, cloudy cornea and at the left side. Also, this is with leptomeningeomata, like related to Sturge-Weber syndrome and OCT. All the finding on the left side with congenital glaucoma, with high pressure, also the axial length at the left side, and compared to the right side, the corneal thickness, the corneal diameter, all with the glaucoma. See, this is the finding under microscope. This is the left eye. On the right eye, see this, the different is right eye is totally normal eye. The left eye, megalocornea, cloudy. But look here at this is how much is the episclera is congested. All the conjunctiva is congested around the limbus. And this is make me slightly more confused when we started. See, this is the finding for the B scan. Also, now, according to my priority, I started to do trabeculectomy. Look now, I started to do the surgery after the section, make ablation. Look, that started the same scenario. This is congested, the episclera vessels so much. Here I stopped on thinking, should I continue on the same priority or change my priority? Asking Dr. Hisham, will you continue or change?
You have to be prepared for explosive hemorrhage if such congestion can happen. So, and you shouldn't induce sudden hypotony of the eye. So I don't know, what did you do? I don't know.
Dr. Zainu, or continue the same or go to AGV directly, change or make, you are prefer CBC, maybe do CBC? Dr. Yasmin, big experience as a child. Yeah, this is. For that, I go to, according to my priority, the same, according to my priority, to continue the surgery, ablation, cautery more and more posteriorly, and only avoid massive cautery over the Schlemm canal to avoid shrinkage the Schlemm canal. And here I continue. Look here, when I open, also make with venous to see I am 100% in the Schlemm canal. When I see the wall of the Schlemm canal, I'm more comfortable. When I complete and find is very quiet, and no problem, no more formation, I complete also with the trabeculectomy. But here I close, usually only close with 2, I close with 4 to avoid the hypotony. If I need any bleb needling or anything, as a trabeculectomy, I go as needling on do in the next examination, but to close the eyes totally and depend on the effect of trabeculectomy in this case. This is the finding 4 months later, and this is everything go very well, alhamdulillah. The axial length is not to cross more. The corneal thickness from 700 to around 400, the same range for the other eye. Axial length is, the corneal diameter is not to grow more and more. And he see this is the child under the microscope. See this, both eye is right eye, that's the normal as usual. This is the left eye, see is now left eye is totally normal. This is superiorly the area of trabeculectomy and the trabeculectomy. This is the finding. The fundus can be seen more clear. There is choroidal hemangioma, clear choroidal hemangioma in the fundus, and this is in the base scan. Don't forget to tomato ketchup fundus. This is very clear picture in this child as the other, but now is more clear with this finding. This is the baby from 6 weeks to 5, around 6 months. I totally quiet, always look to the side, but this is centrally is no strabismus, alhamdulillah, both eye is totally clear. As a summary, when possible, I will not change my priority in this kind of patient, and thank you very much, and welcome all of you to Muscat next month, inshallah, for our conference. Thank you.
Thank you very much, Dr. Ali. I think the surgeons should expect lots of luck to avoid the complications. Yeah. So now can I advise Dr. Akhtas for his presentation?
Dr. Akhtas will present, Dr. Zainab, I think will present virtually. Is on Connect? Yeah, please. Welcome, Dr. Zainab. We cannot hear you. Are you hearing me, Dr. Zainab? Still, Dr. Zainab, we cannot hear you. I think the problem with the connection. Brother, can we go to the next until you make a good connection with Dr. Yasmin, Dr. Zainab?
In the meantime, can I ask you if you have such cases, how to avoid, what are the tips to avoid the...
Can you hear me?
We cannot hear you right now.
But I cannot hear.
Hear you. Okay, let's... now you're online now. We can hear you now.
I cannot hear you.
We can hear you now. Can you hear us?
Are you hearing me, Dr. Zainab? Unmute, unmute.
Whenever you hear me, I don't hear you.
Now we are hearing you.
Okay, I can hear you.
Yeah.
If you hear me, then I can go on.
Yeah, can you go on?
Okay. Okay, thank you.
Welcome, Dr. Zainab.
Okay, so nice to see you all. So thanks. I would like to thank, first of all, for kind invitation. So I'm so sorry for not being able to make it there in person. So now you can hear me now, right?
Yeah, okay, we can hear you. Can you start, please?
Okay.
Thank you, Dr. Zainab.
Now I'm going to start with a case of hypotonia. And I'm going to show management of persistent hypotonia developed after GAT surgery. This case was a 33-year-old male with a history of congenital glaucoma. And he was referred for surgical treatment of hypotonia developed after GAT surgery 7 months ago in another center. So visual acuity was 2200 in the right and 2020 in the left. So patient was phakic with bilateral ophthalmos, and the IOP was 7 in the right eye, and 13 with maximum tolerated medical treatment in the left. And the patient had high cup-to-disc ratios bilaterally. As you see here, there was a ophthalmos in the left and the right, and there was a advanced glaucomatous damage in the left, but in the right, as you see, there were folds, and it was probably the green disease because cup-to-disc ratio is very high. So when we checked on with gonioscopy here, in the left, in the right eye, sorry, there was it goes spontaneously. I'm sorry. In the upper nasal quadrant, there was a deep psychodialysis cleft extending almost 2.5 clock hours, and you can also see the cleft in UBM examination, and IOP was 7 to 8 millimeters mercury, and there was a hypotonous maculopathy here in this case. So what would be our treatment plan in this case? So we put the patient on atropine drop and did argon laser treatment, and then after a week, after a couple of weeks, the visual acuity increased just a little bit, 20/50, and IOP was still 8 millimeters. And but there's still hypotonous maculopathy here in this case. So we decided to go for surgical treatment of the cleft. In these cases, if the patient is phakic, so you need to go for external psychodialysis cleft repair. So you need to check the position of the cleft, and you need to clarify the borders of the cleft just to plan where to make your incisions, because your incisions, sclera flaps of the incisions, the borders of the sclera flap should extend the borders of the psychodialysis cleft basically. So now we are making our incisions to locate psychodialysis cleft here. This is full thickness psychodialysis cleft, and you see here the aqueous coming out, and you see here the borders at the moment. Now we are passing the nylon suture through the ciliary body and through the sclera flap to lift the ciliary body to make a cyclopexy, external cyclopexy. This is what we are doing here. And we're gonna pass a couple of stitch in the same fashion. And then we are going to close the wound as shown here. Okay. So this is the first day of the surgery. So this is actually a good sign for successful cleft repair. As you see here, the IOP is very high, like 42 millimeters mercury, and there is a corneal edema. And because of the corneal edema, this image is not good. But you can see very clearly that there is no hypotonous maculopathy. And you can also see the successful repair here in this UBM examination. And as you see, the corneal edema was gone here a couple of days after the surgery and medications. And on the other hand, IOP was still 24 millimeters mercury with an intact trabecular meshwork here. Now, we decided to go for another gut surgery here in this case. And as you see here, trabecular meshwork is there. And we did successful gut surgery here in this case. You can also see the cleft repair area here on the left-hand side. And suture is in the Schlemm's canal. Now suture is in the exact, correct place. Okay. After the surgery, let's go through some papers. Transient hypotony might occur after any minimal invasive glaucoma surgeries, but it's very low. Persistent hip hypotony is rare. On the other hand, young age and myopia are the risk factors for hypotonous maculopathy. If you look at this meta-analysis, and there are some transient hypotonia reports, like 4% to 2%. And in this paper, psychodialysis cleft was reported after trabecular surgery and successfully repaired with surgery. So treatment plans, first of all, should be medical, and we should start cycloplasia, and can cause relaxation of ciliary body and decrease the distance between ciliary body and the scleral spore. And argon laser and diode laser or cryotherapy might induce inflammation so that it might work. But if they don't work, we can go for surgical treatment. We can do cyclopexy, ab external or ab internal way with suture fixations, or we can perform cyclotamponade internally or externally again. And in phakic patients, internal cyclotamponade might be a problem. But if we are planning on doing cataract surgery, then we can go ahead and do cataract surgery and IOL implantation, and together with CTR to create an internal tamponade. So psychodialysis might occur during gap surgery. So here in this case, trabecular meshwork was totally intact. So we thought that suture probably went into supraciliary space in the very beginning. So it was a false passage in the very beginning of the surgery. So patient needed another glaucoma surgery, and after the cleft repair, he has hypotonic maculopathy, even with 8 millimeters mercury. Probably this is because of the scleral biomechanics and ophthalmos. So the trabecular meshwork was still intact, and we decided to go for angle procedure again. That surgery was performed, and IOP was 16 with medication, with no medication, almost 2 years. And I would like to emphasize that the importance of UBM here in these cases, and locating scleral spore and ciliary body with gonioscopy is very important, is of paramount importance. And in these cases, UBM is a very good adjunct. So it's very important for the evaluation of these patients. Thanks so much for your attention.
Thank you very much, Dr. Zainab.
Thank you. So I'm stopped sharing.
Yeah.
I'm stopping sharing here. Okay.
If we keep Dr. Zainab, and maybe that's good. Are you hearing me, Dr. Zainab?
Yes.
We still have one, two, or two question before disconnecting. Why you go directly to if this is the trabecular meshwork is intact, but we have complication on the supraciliary, or this is with this complication? Why you go to this area, the same complicated area?
Because trabecular meshwork is totally intact. Because the surgeon probably tried to get into Schlemm's canal, but in the very beginning of the surgery, it directly goes to supraciliary area. So trabecular meshwork was totally untouched all the way around. So this made us go that way, actually. But exactly, you are right. If the trabecular meshwork was damaged, so maybe I wouldn't have gone that way.
No, because if this is with this dissect on the cutting the sclera, and this is will not working this area from the Schlemm canal. This is maybe affect the result, your result.
Maybe, but we just repaired the ciliary body cleft. So this surgery area is apart from the Schlems canal. So since the trabecular meshwork looks very good, was looking very good, so we decided to go for another gut surgery because these are, complicated eyes with ophthalmos and patient is phakic. So before just moving on to tube surgery or trabeculectomy surgery, just we wanted to try angle surgery.
Anyone have any question? Dr. Yasmin, Dr. Zainab, anyone from the hall before disconnected? Any question?
I cannot hear the questions because, and you need to forward them to me.
Take the microphone, Dr. Yasmin.
But we do share the urge to address the angle in children before going to filtering surgery. So I would support what Zainab did in addressing, giving one last chance to the angle. This is actually the theme of the next talk, is giving the angle the best chance because it's the less invasive alternative.
Yeah, yeah. This is the way I thought actually. Because they're all complicated eyes, just before moving on to the invasive procedures, we should be done with the angle. So that's why.
Yeah. Thank you, Dr. Zainab.
Thanks,
thank you for presenting these complicated cases. We shift to the next and
thanks so
the
much.
last case. Thank you, Dr. Zainab.
I enjoyed your talks. Bye-bye.
Welcome. The next presentation for Dr. Yasmin Al-Sayed, going 2 steps back. Welcome, Dr. Yasmin.
Hello, everyone. So the usual nomogram for treating glaucomas used to be trabeculectomy. If this didn't work, we would go ahead with another trabeculectomy, or if we prefer to go for a tube straight away, or sometimes if the redo fails, we go with the tube, and eventually we would end up doing a cyclodestructive procedure if nothing else, if all else fails. But over the past years, there's been a recent urge to address the angle in adults as a minimally invasive alternative to the mold filtering procedures with all their risks and over the short and the long term with instruments like the trabectome and the Cahoog duoblade and new techniques like the GAT, which has allowed us to create a whole circumferential incision through a single corneal stab incision. The early outcomes were favorable. The 2-year outcomes of GAT were favorable in primary open angle and secondary glaucoma, but more evidence started to come up that you can even perform it in eyes with previous failed glaucoma surgery. So in this study, when they compared patients that had GAT after a previous glaucoma surgery and those with aversion eyes, the success rate was similar. And in this study that specifically looked at GAT in eyes with previous incisional glaucoma surgeries that included trabs, tubes, trabectomes, and even diode CPC, they found that the success rates were favorable. So over the past few years, 2 or 3 years, I've been shifting my nomogram. So instead, if I'm faced with a failed trabeculectomy or filtering procedure in general, even a tube, instead of going 1 step higher towards more invasive procedures, I go 2 steps back to treating the angle and giving it the best chance. Of course, with proper counseling with the patient. And I'm going to present a few cases. Some of them were success stories and some were disappointments. So the first case was a patient I did a trabeculectomy for a few years back, and then his pressure started to rise gradually over the years as I was following him up. He had very advanced glaucoma. His pressure went up to 22 on combination therapy. So I started discussing with him the option of either doing a tube or a minimally invasive procedure that can reduce the pressure on the same or fewer medications. So we went ahead with a GAT, and in these cases you need to start your rotation away from the trabeculectomy and end the suture threading at the site of the trabeculectomy because it often stops at this point and you get a smaller incision, smaller extent incision. And that was back in January 2020. I've been following him up since then for 1.5 years. Now, thank God, his pressure has been maintained at 14 on the same combination therapy and his visual fields are stable. Now, this case was a more difficult case and more difficult patient, actually. He was a pharmacist with a history of, when he came to me, he had already had an AGV, a Barveld implant. He was aphakic with very advanced glaucoma, and as usual, only eyed. And his surgeon, the Barveld, who implanted the Barveld, he told me that he left a stent in there before he traveled. So I started looking for the stent, and it wasn't anywhere that I could find. So the only options I had were to either do a cyclodestructive procedure, because his conjunctiva could not tolerate another tube, or obviously not a trap, or to do an angle surgery. So I opted for a trabeculotomy for this case, and I did the maximum extent incision of the angle that I was able to do away from the previous filtering procedures. And his pressure was luckily maintained on 7. He wanted to be on full medications. He was a pharmacist, he loved medications, and he wanted the pressure to be on the low side. So I continued to follow him up for months. Now he's following with his local doctor, and he's been fine, but last time I saw him, his pressure has gone down to 7 on 3 meds. Now this young girl was referred to me with an exposed tube. She already had traps, 2 and 1 express implant, and the AGV that was exposed, and a micropulse in the middle. And when I saw her, her pressure was 20 on full medications, including occucarpine and Sidamex. And this is the tube, and I already examined her angle pre-operatively, and I found that most of the angle was intact. Around 300 degrees of the angle was open, with no major PAS. So after removing the tube, I decided to go ahead with a trabeculotomy, again, give the angle the best chance, because the other options were to implant a tube somewhere else or go for a diode. So I did a trabeculotomy. Again, the extent here was around 300 degrees, ab external this time. At this point, I wasn't doing a lot of GATs. And her pressure has gone down to 16, and it's been maintained at this level since then, on no medications. Now, this last case was referred to me with failed traps. He had previously had 3 traps, vitrectomy. His vision was 0.06, very advanced glaucoma, also only eyed, and it looked like he was very scarred. I'm not sure if this was from the medications or there was a suspicion that he had OCP. The only options were to do a diode or possibly give the angle one last chance. He had some narrowish angle, around 20 to 30, but I opted for a GAT, and of course, in these patients, we counseled them about all the possibilities and success, but the fact that we're opting for a less invasive procedure, maybe with a lower chance of success, but it's worth a try. So I completed the GAT with a trabeculotomy to the part of the angle that was not incised. So on the first 2 weeks, his pressure was controlled, but then it spiked to 48 on 2 meds, and I ended up doing the diode that I originally delayed. So in choosing whether to go 1 step forwards towards a more invasive procedure or 2 steps back in failed trabeculectomy or tube surgeries or even diodes, we of course need to consider the challenges inherent to angle surgeries, including the risk of bleeding, the fact that the collector channels may not be working, especially in eyes that have had already previous glaucoma surgeries or with advanced disease, but we always need to remember what we're running away from, all the risks inherent to the more invasive procedures like the filtering and the diodes. So if we can get a surgery that is possibly less IOP lowering, but can lower the medications, give a better quality of life to the patients without leaving them with a bleb, I would definitely opt for the less invasive, even if it gives me a small chance to get away from the filtering procedures. Thank you very much.
Thank you very much. Maybe this is one question, Doctor. Then if we go 2 steps back, why you didn't make this 2 steps back the first step? If the sister, we go 2 steps back, why we didn't make this step the first step from it? Yeah, this is.
I address the angle now as a first. It's been 2 years that I'm doing angle surgery as the primary procedure for most patients. All open angle glaucomas, the secondaries without patchy PAS, too extensive PAS, and even in angle closure, I combine it with phaco, and the results we're about to publish them are very good. So definitely I go for angle surgery as the prime, but circumferentially, because the early results of the limited extent 120 to 180 degrees was not very amazing, so a lot of people did not adopt it. But when you address the whole angle, the results are very good in adults.
Maybe this is the idea, to make deep sclerectomy with a trabeculotomy at the edge of that deep sclerectomy will give more and more successful rate?
Absolutely. Deep sclerectomy is a very excellent surgery. I didn't get a chance to do it early on in my life. I used to do trabeculectomy with releasable sutures. So I think every surgeon has his own preferred surgery that in his hand works best. Definitely deep sclerectomy with trabeculotomy is a great option because it gives you the best of both. I've been doing circumferential trabeculotomy, whether ab internal or ab external, and I'm very happy with the results.
So the belief was that trabeculotomy is meant for children or for congenital. So what was the longest period that, because it might heal, you do like that and that it might heal?
For my cases, it's around 2.5 years now, but GAT has been around for, since 2014, it's been around for 8 years, and the results are quite favorable. We have longer term results. And then that being said, also I'm not happy with the long-term results of trabeculectomies. Maybe deep sclerectomy if I've given it a chance, but even trabeculectomies over the long term are not working really well. The thing is with GAT, it's very minimally invasive. It takes 7 to 10 minutes. And it gives a chance to the patient to at least lower their medications, and sometimes, surprisingly, they stop it altogether, especially in secondary glaucoma. So, for instance, in uveitis, it's really amazing. It can drop the pressure down from 50 to 10s on no meds. In primary open-angle glaucomas, it's probably less effective, and that's supported by the evidence we have, but still, it has a very good chance of lowering the medication. So if you have a patient on full medications, they'll be controlled on a single combination therapy that they can use once at night. So it's really, with good counseling and good patients' expectations, it's changed the way I address the armamentarium of glaucoma that I choose.
Thank you so much.
Thank you, Dr.
So Dr. Gupta is around? Okay. Can I ask you a question about your waiver, the tips, surgical tips to reduce the possibility of the expulsive hemorrhage during the surgery?
First of all, try to decrease the IOP as you can. How much you can decrease the IOP, pre-op, this is very important before any intervention. Sometimes will not respond to any medication, you should go. Otherwise, when you open the eye, try if you can make the trabeculectomy without the trabeculectomy, this is good option. If you make the trabeculectomy, you should be very quickly. In this case, when you start before to make the trabeculectomy, take the 2 suture for the flap to be ready. When you make the trabeculectomy and decrease the IOP, can you directly close? And also here, and I prefer to make paracentesis at the beginning before decrease the IOP. The IOP is very high. I give the paracentesis inside the eye and only move very slowly. This move, any movement decrease 5 millimeter mercury, and after that, go with the paracentesis out. In this step, you decrease the pressure in the eye, for example, from 40 by step 5, 5, 5, until to reach to the 20 before opening the eye, and that will decrease the risk of decreasing the pressure from 40 to 0, and this is decrease the risk for any explosive hemorrhage. Always in any type of glaucoma, if I go on the eye is very high IOP, I try to do the paracentesis with this maneuver because it's very comfortable, and the risk for explosive hemorrhage is very less.
Have you considered OPG injecting?
The second step.
Yeah, okay.
The second step, when I make the paracentesis and decrease the IOP, to avoid more bleeding from the Schlemm canal, I go with the OPD and inject it superiorly, because if any bleeding to come is not to come very aggressive to the anterior chamber and cover the pupil area. Thank you, Doctor. No, AC maintainer I don't prefer. Any comment from, or any question? Please, a microphone to Dr. Zainab.
Thank
Thank you for the presentation. It was really nice. And I would like to ask about your opinion about the CPC. We know it plays a mild role in this group of patients, but in terms of choroidal hemorrhage or choroidal effusion, do you have any cases that you prefer CPC?
With
prior?
CBC?
Yeah.
For me, at least this is with the traditional, I don't have the machine now, but when the last choice, I go with the CBC. I have the micropulse. I make, when this is no other choice, because maybe in the next conference, the same title, but should I in Konya de Lange syndrome? Because in this case, I didn't have any choice to give the child more than 10 minutes under sedation. For that, in this case, I make the first choice. The IOP is 40, a child with Konya de Lange syndrome, protrusion in the eye, start exposure keratopathy. From the anesthesia, giving only 5 minutes to 10 minutes under anesthesia. Otherwise, because very high risk, I make under sedation. I make in 5 minutes micropulse CBC 4 by eye. I give the child 6 months. Later, after that, I go to the trabeculectomy. Also, I change my priority because in this case, I go directly to a glaucoma drainage device, not because I prefer, but because I go to Ahmad glaucoma valve. In this case, because the child, I cannot go for regular follow-up under anesthesia. For that, always you change your priority, depend on the case. Thank you, Dr. Any more questions? Otherwise, we can conclude the session. Very, very good attendance until the last minute in the conference. Thank you all for the attendance. Thank you.